All right, well, we're going to just go ahead and jump right into our next session. So I'm really excited to get to join you from the presenter chair today. So I am both moderating and presenting, and my topic will be artificial intelligence in body imaging. And we're going to really be focusing on the commercially available tools and some unique things that make AI and body imaging very interesting, in my humble opinion. I do not have any relevant disclosures. So my goal today is that we're going to do some background on AI and body imaging. We're going to talk about the kinds of tools that you're going to see in clinical practice. We'll do an overview of these types of applications, discuss some key pearls and pitfalls, and we'll end with challenges and future directions. First, I'm going to get my toolbar out of the way so I can see my slides. Perfect. So as we have mentioned before, radiology is really the dominant force in the healthcare AI marketplace. So 2/3 of FDA cleared AI applications are related to radiology and medical imaging. And there has been some change in this in the past couple of years. Cardiology has made some headway, and there's research and development in all different specialties in healthcare. And investment in AI, but radiology still is just far and away the dominant force in healthcare AI. There are different ways to think about radiology AI applications. So we've talked about upstream, downstream. We have interpretive versus non-interpretive. But the FDA categories kind of put things into different buckets that make it a little bit easier to understand what the purpose of these applications are. So you have medical image management and processing systems, or MIMPs. So these are going to be your tools that are related to either image processing. Maybe they have a non-interpretive role, so they're applied either upstream or downstream from image interpretation. But they can also have some role in image interpretation as well. So maybe they assist with segmentation, maybe they provide other measurements or import other information into the radiology report, but they're not directly related to image finding detection. That would be a computer-aided detection application, or CAD. And there's 3 different subtypes of CAD. So you have CAD-E, which is where you are detecting a finding on exam. CAD-X, which is a computer-aided diagnosis. This is providing a diagnostic assistance or providing a diagnostic category. And then you have CAD-T, which is computer-aided triage. And this is where you have a tool that's integrated with the work list. It might provide a work list flag for an emergent study, but it goes beyond just the image interpreter, or just on the image itself. It's integrated with the work list. So the number of AI applications in abdominal imaging is about at the average for subspecialties in radiology. So there are currently 421 FDA cleared AI applications. 56 of those are related to abdominal imaging, but there's a relatively low proportion of computer-aided detection applications. So a lot of these are related more to image management or processing. So of the 8 computer-aided detection applications, we have applications for prostate MRI, for detection of new peritoneum, detection of incidental vertebral fractures, and the majority of these applications are related to CT and MRI. That's 48 out of the 86, with a few radiograph X-ray applications. Some of these are multi-specialty that they can be applied for both CT, MRI, PET. But there are an increasing number of ultrasound applications, which is new since the last time we gave this presentation just 2 years ago. So that's been an exciting area of growth in this subspecialty. And this is also probably a familiar slide to you as well, that this is taken from the American College of Radiology AI Central Database. This is under a tab I believe is called Current Landscape, but it's a really great way to get just a very, very quick graphical representation of where the field is and where different subspecialties are in terms of how many AI tools are available, what types of tools are available, what they do. And this is very interesting to see this year by year clearance rate that we have, that as opposed to the overall trend in radiology that we've seen significant growth, really exponential from 2017 up until 2023. and then this plateau. It's been much more variable. It's been kind of a pick and mix bag with abdominal imaging. That some years are big years, some years are little years, but we have had an increasing number of computer-aided detection or CAD applications in abdominal imaging over the past couple of years. But some of the notable trends that we see comparing the field as a whole with this image on the left, with abdominal radiology on the right, is that we have a very large proportion of these applications that are MIMPS, MIPS, image processing applications, and relatively few CAD applications. And there are a few reasons for this, and most notably, it's because abdominal imaging has a very heterogeneous set of images that we are evaluating. There's a lot of variability, a lot of post-surgical anatomy, and we don't have quite the same standardization of imaging protocols that we have as you might find in neuroimaging. So in neuroradiology, there's certainly plenty of variability. There's lots of post-surgical changes, lots of pathological processes, but the field of view and what you're imaging on different exams is relatively more consistent from patient to patient, whereas a CT of the abdomen, depending on different patients, can be extremely different from one patient to the other, going from patients with cirrhosis, patients that have had surgeries, patients that we just get a different field of view, maybe the patient is positioned differently. And that can make it challenging to adequately train AI applications when you have such heterogeneity in your data set. You also have modalities that are much more operator dependent. So specifically with ultrasound, two sonographers taking images of the same body part in the same patient could potentially end up with drastically different images based on their technique. And similarly with radiographs, we have a lot of operator dependency with this as well. Another contributing factor for the low number of CAD applications is that there's just a lower proportion of time critical exams. So obviously, if we have a patient that has a stroke, that has pulmonary embolus, pneumothorax, for a stroke, especially time is brain, we need to having a change in turnaround time of even a couple minutes could result in a pretty substantial change in the patient's clinical status and morbidity and mortality. We don't really have quite as many of those immediate turnaround time needs in abdominal imaging. Of course, we do have abdominal emergencies, but not something nearly as common and as time critical as stroke. And another thing that's limiting us in abdominal imaging is we don't have the same number of large anonymized data sets. And we've touched on this when we talked about why neuro has so many more applications than a lot of the other specialties. And that's because they had some of the very early work in these very large anonymized data sets for head CT. And we don't have something really at this point that's equivalent for body imaging. But because of that, we have some more unique tools in abdominal imaging that are different than the profile that you'll see with other subspecialties. So we have some tools that are more tailored towards very specialized exams, tools that can really augment the types of services that abdominal imaging radiologists can perform. And we have some image processing applications like other subspecialties. But since that's such a high proportion of our AI tools, we can dig into that a little bit here. And we have a less focus on the high acuity findings as there are for some of the other subspecialties. So for chest, where you might have a pulmonary embolus application or a pneumothorax application, or in neuroimaging where you might have a stroke application or an ICH application. We have a few that we have vertebral body fractures, we have pneumoperitoneum, and those are CAD triage, computer-aided triage applications, but not nearly as many as some of the other specialties. And this is an image from a paper that we wrote with some of our colleagues here at UAB a couple years ago. We collected this data in 2022, and this is really quite out of date at this point. I think that all of these categories have essentially doubled, some more so in that time period, but it is rather interesting that the proportionality of it has stayed the same. That we have a much higher number of applications that are related to cardiac imaging, to chest imaging, and some more targeted areas that we have different applications that are integrated for imaging of the abdominal organs and of the thyroid. So some of the common tasks that we're going to see with AI applications and body imaging are going to be your image processing, segmentation and quantification applications, and then different radiologist augmentation tools. And we'll close by talking about opportunistic screening, which is a very exciting development that we've had recently in the field. So one area that's been especially targeted has been prostate MRI. This is a highly specialized exam. For readers who are not as familiar, don't do as many of these exams, there can be very high inter-reader variability, and they can be very time consuming for people who are really trying to lock in and find these very, very subtle findings. So the AI application that we're highlighting here, or that was public, or that was in this cited source, the purpose of it is to analyze the prostate MRI images, highlight the key findings, and it provides a PI-RADS recommendation on top of that. So not only is this detecting the finding, highlighting the finding, but it's providing diagnostic support as well. So with what I've told you about this application, so if you had your 3 different types of CAD categories, so would this be a CAD-E, a CAD-T, or a CAD-X? You weren't expecting a pop quiz, were you? So it is providing a diagnostic categorization. So it's giving you a PI-RADS category. So this would be a CAD-X type of application. And the nice thing about this type of application is that it's increasing standardization. It's increasing the quality of the app, or it's increasing the standardization and increasing the quality of the reports that are coming out for this very specialized type of application, or this very specialized type of exam. And having a PI-RADS category really makes the integration of this diagnostic support a lot more easier to integrate, because these are defined categories. You're not having to go through a differential list. Like, this is something with defined features for each category. So PI-RADS is an easy way, or is an easy area to target. But similarly, you can also use this for TI-RADS, for thyroid nodules. You can use this for BI-RADS, for breast lesions. You can use this for Y-RADS, for liver lesions. So having these specific categories makes it easier to integrate these AI applications into practice. Prostate imaging also has a more standardized imaging protocol. You have a small field of view. You have a relatively more consistent region of anatomy that you're seeing. And there's less variability overall with what is included in the field of view. So prostate MRI is one of the targeted areas, and that's because of these specific features, that it's highly specialized. It's an area that really could use more support, where we have higher inter-reader variability, potentially lower quality on the reports, and our less experienced readers could really benefit with this AI support, as opposed to maybe our more specialized readers who might not see the same benefit. So someone who reads a lot of these, who's had some specialty level training, might not see the same benefit as someone who hasn't had this level of training. So another area that we have AI applications is in liver, fat, and iron quantification and our MR elastography. So these are image processing techniques that augment our role as a radiologist. Doing elastography is not something that I, with my human eye, could look at a liver and give you a specific stiffness. But this, and the importance of this is that it opens up a novel service and expands our capabilities of what we can do with the images that we acquire. But this is still a specialized exam. There's extra hardware that's involved. We have these novel imaging techniques that require troubleshooting, and we have to be able to recognize artifacts and false positives, false negatives when they occur. So this is an example here that is perhaps a little bit difficult to see depending on how it's projecting, but on the left, we have a fishbone diagram where we have X's going through the areas that are low confidence, not going to be included in the report. And then we have the source images on the right. So this very unusually shaped region in the middle is where the algorithm is saying, this is where I will acquire my measurements to determine the liver stiffness in this West Virginia shaped region here. But if we look at our source images, that does not seem to overlap with the liver. So unless we are interested in getting the elastography of the gallbladder, right kidney, and perirenal fat, this is not going to be particularly valuable. Another area that we have some applications that are more unique is going to be for anatomy segmentation. So this is very important for our oblong, somewhat unusually shaped organs in the abdomen that we would like to track changes in size over time or have more accuracy when we're determining, oh, is this enlarged or is this small for the patient or for the patient's size? And something that we have, again, a lot of inter-reader variability going from one modality to another or going from one reader to another. So having a 3D volumetric segmentation of the liver can be helpful for cirrhosis, for more accurately determining hepatomegaly. And then if we're measuring specific lesions, then this can be very helpful for cancer imaging, that we can increase our consistency between exams. We can provide 2D and 3D measurements and give a more complete look at how tumor burden is changing for time. Because for anybody that reads a lot of cancer imaging, measuring, remeasuring, and remeasuring again along its target lesions can be very laborious, and having an AI application do this automatically and doing it consistently between studies is very helpful. So this is just an example of what these can look like. So we have CT images of two different patients viewing the liver. And you can see a little bit more clearly between the image on the left, which is a patient with a normal liver size, and a patient on the right who has hepatomegaly. Looking at this only in an axial plane, it can be a little bit hard to make this call, but if you have volumetric measurement that's showing this objectively, would be outside the range of normal, it's a little bit easier to demonstrate hepatomegaly for the patient on the right. And then we have our anatomy segmentations for patients with cirrhosis. And that can be helpful for objectively determining cirrhosis, and it can also be helpful for if you're planning the surgery for HCC and trying to determine residual liver volume. And another tool that we have in abdominal imaging that is applied in a lot of other specialties as well is this deep learning reconstruction AI augmented image processing. This is something that decreases our imaging time and also allows us to acquire diagnostic quality images with less contrast, less radiation, less table time if we're talking about MRI. So this has been a very popular area, a very needed area for AI integration in radiology that's helped us to alleviate long wait times, increase the volume that we can scan per day. And then there's also applications for if we were doing a low field strength, like a large bore 0.55 Tesla magnet. We can use AI to help to fill in the gaps for what would traditionally be a lower quality exam. And then last, we're going to talk about opportunistic screening. This is a relatively novel concept that we're seeing enter the marketplace, that we're using the images that we're getting from typical exams that might be acquired for other reasons to provide additional diagnostic value and objective data for things that patients didn't even come in with. So if you imagine someone that came to the ER that is presenting for right lower quadrant pain, they get a CT abdomen pelvis, and our conclusion is no acute abnormality, no evidence of appendicitis. We have a wealth of imaging data in every exam. So if we're looking at this exam, we can go through and this algorithm would run in the background. It can segment out muscle volume compared to visceral fat, compared to subcutaneous fat. It can provide an objective score of the amount of atherosclerotic disease. It can perform measurements for bone density, and all of these things that really would not be realistic for the human radiologist to do consistently on every single case, but that imaging data is there. So the idea is that we provide more diagnostic value to patients who have already presented, gotten this exam, and gotten the radiation exposure, contrast exposure, but potentially can detect or determine risk factors for other diseases and potentially get them on a treatment path early before they have these complications. So as an example of this here, this is a axial CT image through the abdomen, and this would be an example of the different opportunistic screening metrics that you could be able to generate from this algorithm running in the background. So while I'm screening through this, and I say there's no evidence of appendicitis, this algorithm is going through, it's determining the bone density, risk of vertebral fracture, risk of hip fracture. It's calculating the calcification score in the aorta. It's segmenting out the muscles and visceral fat and calculating the volume of the liver. So all these things that are in the image, but not necessarily part of our search pattern or realistically what we would be looking for in a typical ER patient. So pros and pitfalls of AI imaging or AI and abdominal imaging. It's something unique. It's something good to remember that this is one of the more unique or subspecialties in radiology when it comes to the AI profile. We have a lot of image processing applications, and we have some of the more subspecialty oriented AI applications in abdominal imaging compared to other specialties that are more focused on acute findings and workflow triage. So, this could be a model for other subspecialties as well that we're looking for how to integrate this and increase our quality for very specialty, very advanced, challenging exams. So having the prostate MRI, PIRADS lexicon model that we can provide diagnostic support and we can provide increased standardization and increased quality in our reports with some of these AI tools. We also have different tools that increase the role that we can perform. So our hepatic iron and fat quantification or MR elastography, our different segmentation tools, which can be used in different ways, both to help us with our diagnosis, both also for opportunistic screening, but these can also be used for 3D reconstructions. They can be used for oncologic imaging, tumor benefit, responses to treatment, and the 3D reconstructions can be very helpful for surgical planning too. So we have some very neat radiologist augmentation tools that allow us to provide some novel services, improve our diagnostic performance. But it is very important with these tools that we are able to recognize artifacts and errors when they occur, and especially for those that we might be depending on to increase our quality, that we are ultimately going to be responsible for the output and ensuring that it is correct. So these AI applications that are suggesting a diagnostic category and are highlighting the key findings, we have to be very cautious that we are not overly dependent on these applications and are not trusting their output over our own clinical judgment and our own expertise in training. That's something important to remember for all of these AI applications that are involved in image interpretation. They are radiologist assistant tools. We are still ultimately responsible and liable at the end of the day for the output of the AI application and ensuring that our final report is correct. Opportunistic screening is a neat tool to keep an eye on in the near future. It really increases our ability to provide more comprehensive data from our routine exams. And we will hammer home again, really want to emphasize the risk of dependence, the risk for automation bias, and the need for us to continue to be the experts who are using these tools and not the other way around. So looking into the near future, I hope that we will be having more development of our computer-aided detection tools, a lot of opportunity in abdominal imaging to bring in more interpretation-related AI. There has been a bias towards more high acuity, high volume exams. So there is opportunity for bowel pneumatosis, portal venous gas, trauma, GI bleeds. So following some of the work that's been done in other subspecialties, we can bring in these acute findings as well. And increasing number of training or the amount of training data and finding new use cases in abdominal imaging helps to broaden the field. There's still a lot of opportunity in ultrasound, radiography, and fluoroscopy. We'll be talking about this a little bit later in the week as well. The challenges with this are the less standardized imaging protocols, more operator dependency. But as we become more adept with these techniques and understand what we need and what makes for a good data set, this becomes a little bit more accessible. And of course, to really make sure that we as a field are prepared for AI integration, we have to continue increasing our access to AI and radiology training. So this is something that we have been trying to make more accessible through our course. All of our topics are recorded and are available on our YouTube channel. I highly recommend that as you go through, if there's a topic of interest and you want to learn more about it, check our page if there's to see if there is a topic that we have covered before. And if there's something you would like covered, please reach out to me and I would love to collaborate and get this or get topics of interest integrated into our courses in the future. All right, and those are our references, and I will be happy to take any questions.
I do have a question.
Yes, question from the in-person audience.
Just kind of thinking about how iterative medicine is, and particularly like different. I guess using an example that you gave with PIRADS, ACR's PIRAD system. Maybe it's not the best example because there are only two or three versions in, but anyway, thinking that over time as the ACR, other bodies, whatever it may be, continue to iterate on these screening or diagnostic guidelines, how and the size of some of these imaging databases that are used to train these models. Say next year, a new version of PIRADS got released. How significant of an investment of time would it, in energy, would it be to retrain a model on a new set of parameters like that?
Now that is a very good question. So the question is, so with regard to the iterative nature of medicine and the changing of guidelines, so if we were to have a new version of PIRADS that came out, what would the burden be on our vendors to update this, be concordant with the new model? And that's a very good question. I don't have a specific answer for you, but that, I mean, you raise a great point that medicine is not static, and these tools that come out have to continue to be evaluated and have to continue to evolve. And if there is something that's major like that we have an update, updates to LIRADS algorithm, update to PIRAD, update to TIRADS, BIRADS, that could potentially require a huge amount of investment from the vendors to make sure that they are compliant. Either that or would require a pretty glaring pop-up box to notify this is not up to date with the most recent PIRADS. Please use your clinical judgment. Blah blah blah. But at least in the United States, where the FDA cleared AI applications, at least my understanding is that they do not continue to retrain their application after it has been submitted and after it is in the marketplace. It is continually evaluated to see if there's any evidence of algorithm drift, which is where you start to have decreased performance over time, or if there's evidence of bias where you start to notice, oh, this is performing more poorly in this region or on these scanners or on these patient populations. But when I give my feedback through to one of our AI applications and say, oh, this is a false positive, this is the reason for it, and then we send it to the AI vendor, they're not using that to retrain at that time, because every time they retrain, they would have to get FDA clearance for the new version. So that is a much more substantial lift for these vendors to be having to retrain at each step. So yeah, if there's something substantial like a shift in the PIRADS category, that would definitely require some retraining. But it would be energy intensive, like we've said, it would be time intensive, and it would also require another round of FDA clearance. So it would be logistically very a big lift too. That's a very good and insightful question.
That's helpful. Thank you.
All right. I know that we are over time again. We will keep better to our time frame over the next couple of lectures. I appreciate everyone's patience with our Zoom issues for the past couple of days. But we'll see you again tomorrow, where we will reconvene at noon Central Time. And I hope everyone has a great rest of the day. Thank you.